Hello, friends. Today I'll be talking about endometrial carcinoma. Endometrial carcinoma is a type of cancer that originates in the endometrium, which is the inner lining of the uterus. It is the most common gynecological cancer in developed countries and primarily affect postmenopausal women. Now, let's talk about the risk factors. Well, the risk factors are unopposed estrogen exposure, obesity, polycystic ovarian syndrome, nulliparity, late menopause or early menarche, tamoxifen use, and Lynch syndrome. Patient usually presents with the symptom of postmenopausal bleeding, can also present with intermenstrual bleeding in premenopausal women and pelvic pain or pressure in advanced cases. For diagnosis, endometrial biopsy is the most common and reliable initial test. Transvaginal ultrasound, if endometrial thickness is more than 4 mm in postmenopausal women, is concerning. Hysteroscopy or dilatation and curettage is done for unclear cases. According to histology, the endometrial carcinomas are of two types: the endometrioid adenocarcinoma, which are the most common ones, and non endometrioid carcinomas, in which comes the serous carcinoma, clear carcinoma, and the mixed carcinosarcomas. So, type 1 endometrioid adenocarcinoma is estrogen dependent and arises from the endometrial hyperplasia. It is typically well to moderately differentiated and common in perimenopausal or postmenopausal women. The histological features are glandular architecture resembling normal endometrium but crowded and complex, may show cribriform or willow glandular patterns. Cells may have pseudostratified nuclei, prominent nucleoli, and mitotic figures. Squamous differentiation may be present. It can be graded according to the FIGO staging in grade 1, grade 2, grade 3. Grade 1 if there is less than or equal to 5% solid growth. Grade 2 if 6 to 50% solid growth is present, and grade 3 if more than 50% solid growth is present. The type 2 non-endometrioid carcinomas are estrogen independent, more aggressive, and arises in the atrophic endometrium. In it comes the serous carcinoma, which shows papillary structures, high nuclear grade, samoma bodies, frequent TP53 mutations, and resemble ovarian serous carcinoma. Here in this image, you can appreciate the normal endometrium, grade 1 endometrioid, grade 3 endometrioid carcinomas, and the serous carcinomas and the clear carcinoma. In this, you can see the back to back arrangement of the type 1 endometrioid adenocarcinoma. The clear cell carcinoma have cells with clear cytoplasm, hobnail cells. They have tubulocystic papillary or solid patterns, and these are high-grade tumors with poor prognosis. Coming to carcinosarcoma, which is also known as malignant mixed Mullerian tumors, these are biphasic tumors with carcinomatous and sarcomatous components, highly aggressive and rare. Talking about the IHC markers of endometrial carcinomas, ER/PR is positive in type 1 endometrioid carcinomas, P53 is overexpressed in type 2, P10 is often lost in type 1, K161 is high in high grade tumors, and MMR proteins MLH1, MSH2, MSH6, and PMS2 are lost in Lynch syndrome or sporadic MSI. Recent classifications include molecular subgroups for better prognostication, in which comes four types of molecularly classified endometrioid carcinomas. One is pole ultramutated, which has the best prognosis. MSH1 or microsatellite instability high has intermediate prognosis. Copy number low uh, has intermediate prognosis, and copy number high, where P53 is abnormal, has worse prognosis. Surgically, endometrial carcinomas are staged from stage 1 to stage 4. Stage 1 is confined to the uterus. Stage 2 involves the cervix. Stage 3 has local or regional spread, and stage 4 has distant metastasis. Talking about the treatment, surgery remains the mainstay. Total hysterectomy plus bilateral salpingo-oophorectomy plus lymphadenectomy is done. Radiation therapy is used in higher stage or high risk disease, chemotherapy for advanced or recurrent disease, and hormonal therapy for certain low grade hormone receptor positive tumors.